Thank you for tuning into this edition of The Science Behind, where, in just a few minutes, I will briefly describe the science behind the Total Thrombus Forming Analysis System, or T-TAS. My name is Matt Soba, a Scientific Product Manager at Diapharma, and I will be your host today. If you have any questions, please do not hesitate to reach out to us by email at info@diapharma.com. Please visit our website at www.diapharma.com for additional information and resources for your use. When the vasculature is injured by, for example, cutting yourself with a knife while washing the dishes, subendothelial collagen and tissue factor are exposed to the blood. The exposed collagen is very important for hemostasis and blood clot formation as well as primary hemostasis. There's a glycoprotein always present in the blood known as the von Willebrand factor. It will bind to the exposed collagen and actually aggregate with itself. This self-aggregation is regulated by a protein called Adams 13. Thrombotic complications can result when this self-aggregation is out of control and will be the subject of a different talk. The shape and conformation of these von Willebrand factor multimers and its ability to correctly bind to exposed collagen is dependent on the shear forces exerted on it by flowing past the endothelial wall. Now, platelets have multiple receptors on their cell membranes. One of these will recognize and bind to multimeric von Willebrand factor. The plate will then be shuttled down to the collagen, where another one of these receptors will bind directly to the collagen, leading to platelet activation. Upon activation via collagen and von Willebrand factor under shear stress, the platelet will change shape. It will become sticky by exposure to the GP2B3A receptor, and it will release granules containing, amongst other things, ADP and thromboxane A2. ADP will bind nearby platelets at the P2Y12 receptor, which will attract additional platelets to the area and increase aggregation. Thromboxane A2 will bind nearby platelets at the TP receptor. This will not only increase aggregation, but also will induce degranulation, releasing additional ADP and thromboxane. Another key method of platelet activation is at the PAR1 receptor. This receptor binds to thrombin that is activated concomitantly by the coagulation cascade. Seeing as activated platelets release factors that either attract or activate additional platelets to the area, it is easy to see that platelet activation progresses in a feed-forward mechanism. GP2B3A activation allows the platelet to bind to the fibrin being generated in the coagulation component of hemostasis. The mesh of platelets and polymerized fibrin is what primarily constitutes the mature plug that will arrest bleeding or blood flow in the case of some venal or arterial emboli. Given the role in clotting of all sorts, including ischemic stroke, heart attack, and venous thromboemboli, it isn't surprising that there are a number of different classes of platelet inhibitors, several of which are very common. Leading off with aspirin. This drug irreversibly inhibits cyclooxygenase 1 from catalyzing the first reaction, converting arachidonic acid to thromboxane A2, thereby preventing activation via this route. Next are the thiopyrimidine class of inhibitors. This class of drug blocks the P2Y12 receptor, preventing ADP binding, signaling, and aggregation. Examples are clopidogrel, Plavix, ticagrelor, and prasugrel. The last of the orally available platelet inhibitors is cilostazol, a phosphodiesterase inhibitor which inhibits platelet aggregation. There are also two classes of intravenously available platelet inhibitors. The GP2B3A receptors, abciximab, abtifabetide, and tirothabam are all examples of this class of inhibitor. This class of drug prevents aggregation of platelets to one another and to fibrin. Also available are the direct thrombin inhibitors, such as argatroban, which will prevent platelet activation by removing thrombin from circulation so that it cannot bind to the PAR receptors present on platelets. The normal number of platelets present range from about 100,000 to about 400,000 platelets per microliter of blood. Thrombocythemia and thrombocytosis are both instances of too many platelets, with the clinical designation being 500,000 per microliter. It's called thrombocythemia, or primary or essential thrombocythemia, when the mechanism is unknown. Overproduction of platelets in the bone marrow is the actual cause, but the why is unknown, and it makes up a small minority of cases. Thrombocytosis, or reactive thrombocythemia, is the name that is used when the why is, in contrast, known. Typically, an infection, chronic inflammation, or a tumorous malignancy are the driving force of the high platelet count. These forms account for the vast majority of cases. Thrombocytopenia is the name used for having too few platelets. The condition is classified as severe if the number falls below 50,000 platelets per microliter. Thrombocytopenia can be genetic in nature, such as in the Bernard-Soulier syndrome and some forms of von Willebrand disease. It can also be acquired. Examples include heparin-induced thrombocytopenia, Zika virus infection, or as a result of chemotherapy. A person with dysfunctional platelets may have a normal number of platelets, but they do not work correctly for various reasons. Glanzmann's thrombothemia, and the inability to form platelet-platelet bonds, is an example, as is many forms of von Willebrand disease, and the ability to form platelet collagen bonds. The T-TAS is a microchip flow chamber system to analyze thrombus formation under flow conditions. A micropump pushes the whole blood through the capillary at a steady state, while a sensitive pressure sensor measures the pressure exerted on the blood to achieve the desired flow rate through the microchip. Each chip contains 2 channels in parallel. Each contains 26 collagen-coated microcapillaries. As the blood flows over the collagen-coated, platelets will adhere to and aggregate on the surface and one another, slowly occluding the channel. As this occlusion progresses, the pressure required to maintain a constant flow rate increases and is measured and visualized graphically. As can be seen, the curve does not always ascend perfectly. These sudden drops in pressure when shear and lytic forces overcome the platelet fibrin bonds and send a piece of clot down the channel and begin forming a new clot is a dynamic process. 26 parallel channels allow for a smoothing out of the effects and for internal normalization of the individual channels. Data are reported out as the area under the curve, AUC. This number integrates the various drivers of primary hemostasis, the lag time to first formation, rate of platelet aggregation, as well as the dissolution of said aggregates. A high AUC value corresponds to appropriate platelet clotting function, while a low AUC value, conversely, corresponds to a weak, deficient, or inhibited clotting. The T-TAS 01 with PL chip is FDA cleared for the analysis and evaluation of platelet thrombus formation, primary hemostatic function, in patients receiving antiplatelet therapy such as aspirin, clopidogrel, prasugrel, and ticagrelor, and in patients with congenital platelet dysfunction such as von Willebrand factor and Glanzmann's thrombocytopenia, though others have not been tested. Thank you for watching our brief introduction and to learn about the science behind the total thrombus forming analysis system. If you have any questions you would like to ask, please email us at info@diapharma.com and visit our website at www.diapharma.com. Thank you.